Good morning, everyone. My name is Dr. Jodie Guest. I'm an infectious disease epidemiologist and professor and vice chair in the Department of Epidemiology at Rollins School of Public Health at Emory University. I lead Emory's COVID-19 outbreak response team working in hard-hit communities in Georgia, and I'm pleased to be the host for Emory's COVID-19 Facebook Live events, where we cover topics about the COVID-19 pandemic. Today, I am pleased to be joined by Dr. Jay Varkey. Dr. Varkey is an associate professor in the Department of Medicine in the Division of Infectious Diseases at Emory's School of Medicine. He is also the director of the Antimicrobial Management Program and associate hospital epidemiologist at Emory University Hospital. Good morning, Dr. Varkey, and thank you for joining me today.
Good morning, Dr. Guest, and please call me Jay, but always glad to talk with you and glad to join you up again for one of these Facebook Lives.
Well, thank you. So let's go over some numbers for a moment to use as a backdrop for our conversation today. Unfortunately, they are not good. Globally, COVID-19 has sickened more than 56 million people. To put this into some context, the last time you and I were doing this Facebook Live together, we were at 38 million cases. We've gone up almost 19 million cases since you and I did this just a month ago. In the US, we have passed 11.6 million cases. And to put this timing into perspective, we hit 10 million cases on November 8th. And in the past 10 days, we've seen an increase in 1.7 million additional cases. The US has also seen deaths increase by 38% in the past 2 weeks. COVID-19 related deaths are still well below their peak spring levels, but have averaged more than 1,000 deaths a day since November. Hospitalizations are at an all-time high with 48% increase in the past 2 weeks, with more than 73,000 people in hospitals today due to COVID-19 across the US. And 22% of our hospitals in the US are saying they don't have enough staff to care for all the COVID-19 patients. So Dr. Varkey, we're gonna actually start with that. What are your thoughts about our hospitalization rates and your concerns as we head into this winter season?
Yeah, I think you painted a very grim picture, and that's what I've been telling my colleagues that I work with in the hospital. And I know the numbers can get almost dizzying when it gets this high, but I think to make it relevant for folks who work in the hospital and for the general public, I think the key is that there is widespread, uncontrolled, widespread growth of COVID-19 infections throughout the country. So if you look at these three different phases, because it's not really assertive, we never actually have controlled the outbreak. But if you look at the spring surge in March, which is largely driven by severe infections in the Northeast, largely New York and New Jersey, the summer uptick that we saw, the summer surge that we saw in the Sun Belt that we felt here in Georgia, this is different. This is widespread throughout the United States, hitting almost every single state, but largely driven by the Midwest, where in the Dakotas, Wisconsin, Minnesota, Illinois, and Iowa, new cases are actually increasing exponentially. But the key about this is that this isn't just limited to cases. These are people. And when the cases are this high and increasing at this rate, people are getting hospitalized. And this is the key thing I want to emphasize. There are more people hospitalized today in the United States with COVID-19 than at any other point of this pandemic. So that's almost 76,000 people. And what we know is that when infections increase, hospitalizations increase. When hospitalizations increase, there's a larger number of people with severe infections, which means deaths increase.
Yes, and right, you're exactly right. So 75,000 people in the hospital with COVID-19 right now. Our peaks in the spring and the summer were only 60,000 hospitalizations. And when I say only, I can't believe we're using that to describe 60,000 people in the hospital. So we always need to remember the delay from cases to hospitalizations to deaths, absolutely. As we compare death rates now, as we're approaching the winter months, to the death rates we saw in the spring, is there any reason to believe that the death rate is actually slightly lower now?
There is. And I think like most of, the topics we're going to talk about in most of COVID-19, there's kind of a half glass full and half glass empty portion of each of these topics. The half glass full is that I think we have learned how to better care for critically ill patients with COVID-19. And part of this is how we've advanced the science. Part of this is through the hard work of our intensive care unit nurses and physicians. So death rates have decreased. but they're still too high. And the fact that we're still having over 1,000 folks in the United States die each year of complications of COVID-19 is way too high. And as hospitalizations increase, I expect that to grow higher. The other part of it that is really critical when you talk about as hospitals saturate, and one of the differences where we are now compared to March, in March, almost every major hospital, not knowing what that surge would look like, stopped doing elective surgeries. There was a point in time where my hospital at Emory, where we are staffed to take care of about 600 people, only had about 300 people in the hospital, half of which had COVID-19. So there was a large portion that was, felt empty. The reality is that almost every single hospital has gone back to normal operations. We have to. People still have diabetes. People are still getting strokes. People still are getting cancer. People still have surgeries that are no longer elective. And because of that, the margin of our ability to care for these surges of COVID-19 becomes much more tenuous. And I think that's a really key aspect for the public to notice, because we need the public to actually engage in the practices they need to do in order to make sure that hospitals don't get overwhelmed.
Great, wonderful. And that's absolutely the right message we hope everyone is hearing. As we move into the winter months, and we normally would be talking about the flu season, what are our predictions for the flu season?
Yeah, I think time will tell. I think that if we are fortunate, and if our flu season follows what the Southern Hemisphere experienced, so for example, what Australia had this summer, our summer, their winter. Right. Australia had a remarkably mild flu season. And part of that is because all the different interventions that we're doing to try and prevent COVID transmission, physical distancing, wearing a mask, washing our hands, all of those are actually highly effective actually preventing flu transmission. On the other hand, I remain nervous because the reality is that here in the United States, we've never done any of those interventions to the degree of countries, including Australia, that have actually helped contain this better than we have. So what I think is a realistic estimate is that I think we may delay the flu season, but I think we will still have people who get the flu and require hospitalization for the flu, which is another key point I'd emphasize. Even though I've been telling most people, please get your flu vaccine no later than Halloween, it's still not too late because we've actually pushed the flu season. It is incumbent that every single person over the age of 6 months, which basically means everybody in the country other than babies, should get their flu vaccine. It'll decrease your chances for hospitalizations, and again, it'll buy us more breathing room in hospitals when we're caring for patients with COVID.
Wonderful. So everyone watching, please know it's not too late to get your flu vaccine. Please get one. All right. As we move to Thanksgiving time and other holidays that rapidly follow, let's talk about incubation periods and what it really means. So if we're planning to get together with someone who's outside of our normal household group of individuals that we see, what do we need to do timing-wise to prepare to protect them and ourselves?
Yeah, it's such a great question, Jodie, because incubation period is one of those things that even non-ID, non-epidemiologists sometimes kind of stumble over. And this is just the way the viruses behave. So the example I would give is that if I got exposed to the SARS-CoV-2 virus today, if I had lunch with a coworker and that person was pre-symptomatic, they're infected, they're infectious to other people, but their symptoms are only going to start tomorrow. I'm exposed, but I'm not going to immediately develop symptoms. That starts the incubation period. And I think most people have seen this incubation period described as 2 to 14 days. The reality is that we know the incubation period for most people, about 90% of infections, is actually within a more narrow window. And it's probably, most people will develop symptoms 4 to 7 days after being exposed. So why is this important for Thanksgiving? The first part I would say is that if you can, and again, I say this hard, I've celebrated Thanksgiving with either family or friends every year as an adult. But this year, if you're able to, this might be a good year to take a mulligan and keep Thanksgiving localized to your household. If you share a meal where you're unmasked with folks outside of your household, there is no zero risk way of doing that. To your question about how to minimize risk, The best advice I'd give people if they can is this is the time to start sheltering in place. So this is time to really limit activities outside of the household to make sure everybody else within your household limits those activities if they're traveling with you, if you choose to travel. But the part of the incubation period where I see people make mistakes is getting falsely reassured by a test. In other words, I know people are interested in getting tested before traveling, but if I decide to go out to karaoke on Friday and with a bunch of my friends and am in one of these super spreader settings, and then I get tested 48 hours later planning on this Thanksgiving trip, that's too early to actually have a test, even though I've been exposed. And what can happen is my test will come back normal because I'm in that incubation period. I will travel. I will be assured the fact that, well, I took a test. I'm good to go. I will then arrive on day 5 after exposure when I'm infectious to my loved ones. And in that setting, I can go and I can meet my parents who I haven't seen in over a year, or folks, friends of mine who are immunocompromised and say, no, it's okay. I work at Emory. I got tested. But I'm in fact infectious because I got tested during that incubation period. And it is critical that the general public not make that mistake because there could be severe consequences.
Wonderful. Thank you for that. Karaoke kind of makes me laugh. That's so 2019 at this point.
Very true.
Yes. I'm also taking a mulligan from Thanksgiving. I've always spent it with my family in Kansas City, and this is not the year to travel, unfortunately. All right. Lots of conversation in the past couple of days about vaccines. So let's talk about 2 different vaccines that there's been information in the media, both Pfizer and Moderna. So Moderna, I spoke with Dr. Kelly yesterday about Emory's role in it and the very exciting news. What are your thoughts about what we're hearing from both of these vaccine trials?
Yeah, I think as somebody who's often cynical and kind of cautious to get too optimistic, I will say that this is a welcome light, or I'll say lights at the end of a very long, dark tunnel. And this should be a reason for hope. And I hope that the general public sees this as reasons to kind of, as hard as it's been for months to try and do the right thing, to try and prevent the chain of transmission, if we can just hang on for a little bit longer, hope is on the way. And I'm increasingly optimistic that mid 2021 will actually look a lot better and closer to normal than I did even a couple months ago. So what we know now that we didn't know 2 weeks ago is that the initial interim analysis of those 2 vaccines, so the Pfizer product and the Moderna vaccine, which structurally are actually very similar, they use the same mechanism, look to be not only safe, but highly efficacious. And efficacious is just a medical term or an epidemiological term for effective. When you're doing a study, it's efficacious. You hope that translates to real world effectiveness. And again, I think it's important to put this into numbers. The FDA was hoping for just 50% efficacy, and
right.
Both Pfizer and Moderna are quoting over 90% efficacy, which again, I think that means to me that we actually have an opportunity, if we do this right, to actually not have COVID-19 be necessarily a chronic thing that we have to live with, but to really nip this in the bud, where we can get to a goal at some point, maybe even in 2021, of not having to hospitalize people with severe complications of COVID-19. I'm going to pepper this with just one word of caution, which is at this time, as my friend and neighbor, Dr. Kelly, kind of discussed with you yesterday, we don't have peer-reviewed data to actually look at. We simply have the press releases from both companies. However, Pfizer made it very clear this morning that they are submitting their entire packet to the FDA as part of an emergency use authorization or EUA application. And with that, that'll be thousands of pages of data on their 43,000 volunteers as part of their phase 3 study that will go to the FDA career scientists to vet the safety and efficacy as part of their EUA application. And that's why I remain cautiously optimistic that by late December, we may actually have actual people, not just volunteers, but actual people get vaccinated with one of these 2 vaccines, with hopefully more on the way in 2021.
We can't wait, for sure. Pfizer's data this morning they released talked about 95% effectiveness for those 65 and older, which will be one of the earlier groups that will be eligible for vaccinations when they're rolled out to the general population.
Yeah, absolutely. And I would just add to that, and this is something that I'm sure we can discuss more, I think it's important to realize that those initial doses, even though there might be a huge clamoring for it, there's going to be a paradox in the sense that even though Emory was one of the test sites for the Moderna vaccine, we don't have vaccine to provide the general public yet. The allocation and distribution of those vaccines is going to be a huge operational challenge that'll cut across the federal government, the state government, and actually local municipalities. And to that end, even as a physician, as part of one of those groups that's going to be in the kind of priority group, I don't expect to actually have access to a vaccine until probably spring 2021 at the earliest.
Okay, well, so we all need to know good news coming, not here right now for all of us. And okay, let us move to a little bit more holiday conversation. Let's talk about going out and doing Christmas or Hanukkah shopping. Is it safe to work or shop in a retail environment if everyone is masked and distanced? And I think those two caveats, everyone being masked and distanced, are probably not our reality.
Yeah, I think I'm going to couch this because, again, as you and I have delved deep into this, it's critical that we kind of talk to the public as adults. Right. Which is the recognition that none of these interventions, especially when community rates are so prevalent in many of our communities, are risk-free. But I think to your question, I don't view shopping as terribly more risky than grocery shopping, which most of us have done going back to March. But it's critical if we do that we not get reassured by just a mask alone. Because again, if you're wearing a mask and you're in a mask-crowded, some horrendous Black Friday scenario that I can't even fathom, where you're stacked, person to person in an indoor big box store, that makes me very nervous. And similarly, I think it's important to know what masking practices are in your community. If those stores still include large numbers of people, or even some number of people that are unmasked, that increases the risk in terms of shopping. And again, I always try and tell the public what I do myself. I'm going to be doing most of my shopping online this year.
Yes, me too. It also lets me delay my shopping a little bit.
I'll also be doing that too.
It's better in 2020 for sure. And as we think about widespread community risk, I want everyone who's watching to follow a particular number, which is the positive percents of those who are being tested. Would you like to talk a little bit about what we think about those numbers?
Sure. No, it's I think that's something that's, in addition with vaccines, my hope is that we will have a whole slew of fast, frequent, convenient, cheap testing for the general public going into 2021. I think that'll be the new normal. And we're not quite there yet, but my hope is the same access that the White House, the NBA, the NFL, movie studios have to frequent testing that we can provide the general public. The key there, though, is what that percent positivity is. So when you see the percent of tests start to creep up, it is a alarm bell that there is increasing community transmission. The goal is really to have percent positivity of less than 5%, ideally less than 1%, which shows you that not only do you really mitigated community transmission, but you actually then can do what your group has done at the Rollins School of Public Health with great success, which is really test, trace, isolate. Once you get percent positivities more than 5%, you have active community transmission. When it goes over 10%, or what they're seeing, my sister is a physician in Chicago, and at her hospital, the percent positivity last week, and Illinois has exponential growth right now, was over 30%. That is frightening. And that actually shows you that you're not testing enough, because that means that you only know about those that are being tested. There's almost undoubtedly many more people who are pre-symptomatic, asymptomatic, that are shedding in the virus, or shedding in the community. And that may be a trigger for, even though I hate to use that word shutdown, at least some of the constraints or societal things we can do to limit transmission.
Great, thank you. So everyone, make sure you can watch on your state health department for that positivity rate. And again, 5% is where we feel we can still control it. We've got several states that Kansas and South Dakota are both upwards of 55% in their positivity in the past 3 days. So really out of control transmission there. The other thing to note is averaging that across the state is a little bit of a problem. You're probably better off looking at county level data for this. The closer you can get in, the more you'll really know what your community looks like. Okay, so Georgia is 40th in the nation for new cases. What are we doing that is better than other states, or is it just that we are being outrun by other states and their infections?
Sadly, I believe in fact, I not just believe, I think there's good data to show we're being outrun. So I'd love to say that we figured it out all in Georgia. I will say that one of the benefits of the severe summer surge, and again, fourth week of July, Georgia had the highest rates of new COVID-19 cases in the country.
That's
So
right.
we've been where the Dakotas have been, maybe not to that degree, but we've been number one in a way we don't want to be. I do think that was a trigger for people, hopefully enough people to start doing the right thing. It can be just hard to maintain. But what's happening right now in Georgia is that rates are going up. They just simply aren't going up to the same degree as large parts of the country, especially in the Midwest. So unfortunately, what I'm telling you, what I'm telling the public is the same thing I'm going to tell my medical staff at our open forum tomorrow, is that we need to be prepared, because I expect cases in Georgia to increase and hospitalizations to increase, and unfortunately deaths to increase over the next couple of weeks. The decisions that are made in the general public today will have a direct impact on the number of people hospitalized 2-3 weeks from now, and those that die of COVID-19 complications 4 or 5 weeks from now.
Thank you for making sure we're always thinking forward about this, not just forward to vaccines, but forward to what our decisions each day will do for us. And to make sure everyone is aware, we're somewhere close to 2.5 to 3 times the number of cases we had back in April in Georgia. So, and our numbers have gone up. They're not quite what they were in August, but we're definitely on our way. Back to hospitalizations. Should anyone be putting off elective outpatient procedures at this point in time, given that we are seeing such a run on hospital beds?
No, not at this point. I think depending on your municipality, I think those are some hard decisions that places in the Dakotas or in Iowa or in Nebraska may have to make, especially if there is a critical shortage of ICU beds. But one of the things that we know now that we didn't know in March is that I truly believe that we've learned how to care for people and to do routine care or even urgent care in a hospital in a way that maintains safety for patients, for staff, and the general public. So my advice is talk with your doctor, but as long as there is capacity, I would not put off these things, because again, we did that in March and we ended up with a lot of people who had surgeries that at the time in March were elective, but by the time we got them scheduled for operations, those have become much more urgent by late spring, early summer.
Right, thank you. 2 questions about vaccines again. If we get the vaccine, is there a reason to believe we won't be able to spread it to others? So not only is it preventing it in us, but is it going to keep us from being able to transmit it?
Yeah, that's the goal. And I am actually cautiously optimistic that that'll be the outcome of vaccination. And just to dig a little bit deep into that, I get the idea of vaccine hesitancy. There's always been portions of the general public that have been nervous about vaccines well before the COVID-19 pandemic. But just to touch on these 2 vaccines that have been in the news so much the last couple of weeks, these are constructed by basically material that creates proteins and that triggers immune cells. It does not actually have live virus, so you can't get COVID-19 from the vaccine. And to that end, because the immune response is so robust, not only do I think that it's actually going to be protective to the person who receives the vaccine, I do think it'll be protective to other people. And that's how we get real herd immunity, not just by letting infections go uncontrolled, but through controlled dissemination of safe and effective vaccines.
Thank you. Yes, herd immunity should be through our vaccination programs for sure. Oh, speaking of herd immunity with vaccines, if I get the vaccine and I'm out in a population and other people haven't had it, what percentage do I need for them to have had the vaccine for us to all be safer?
Yeah, great question. And that number can vary. So again, I'm going to give a range, but I think if you look at other infections, most people extrapolate that you really need to have anywhere from 65 to 80% of the population with immunity in order to say that there is herd immunity, that those that don't have immunity still have some degree of protection because of the widespread immunity in the community. which gets to another critical point, is that as we understand immunity, I think that we should mentally prepare the fact that a lot of these interventions, whether it's masking or not crowding, that we're going to have to be patient and recognize the fact that it can't just be get your vaccine and, oh, I've got my get out of jail free card and I can do everything I want. There are still going to be constraints. And again, recognizing that not every one of these vaccines may have 95% efficacy. I would have taken a 70% efficacy vaccine and been thrilled. But that means that if I get that vaccine, there's still a 30% chance that I didn't actually develop immunity, which is why I still need to be masking, which is why I still need to be protective of others.
Great, thank you for that. And children, both of these two vaccine trials have been in 18 years and older. So what do we know about children and vaccines coming up?
To be determined. So a couple of these trials have actually started enrolling those under the age of 18. But as you said, all of the data we have to date are all over the age of 18. So that's the other piece that I would add, because I know you and I both get a lot of queries from parents. One of the things I hope that we really prioritize in 2021 that I think that many of us, myself included, missed the boat on in 2020 is the opportunity to safely reopen schools. Mm-hmm. And that's going to require two things. One is recognizing that we need to recognize our teachers as critical workers and prioritize them and empower them and making available these safe and effective vaccines, assuming the fact that the data that has been presented so far bears out in the FDA review. But I also hope that by doing so, we recognize that kids might not be able to be vaccinated right away. But if we as adults do our part in getting vaccinated, we can more safely reintroduce kids into school and hopefully keep them protected from each other and to their families.
Wonderful. Thank you. I definitely share your point of view that schools reopening is a priority of a lot of different events that could be opened. One last question about vaccines, other trials that are out there. They're not all mRNA vaccine trials, but how are the other ones going from what you've read so far?
Slower, but well, so far as I understand. So my understanding is that there are several others, using more conventional platforms, protein-based, viral vector-based vaccines that actually are accruing patients, of which I think those phase 3 studies will likely complete during this winter. And then again, the paradox of having uncontrolled spread is that the time from which a study completes to actually getting outcome data has gotten really short because there's so many cases coming out, as we've learned from Moderna and from Pfizer. So I think with some slower accrual, I think that what I would tell the public is that it's in our best interest to have a large armamentarium of different vaccines. And the first might not necessarily be the best. The first might not be the one that most people get. I think we need to kind of build our bench strength with what's out there. We have an entire world to vaccinate, and it's going to take kind of this all hands on deck approach.
Yes, an entire world to vaccinate. Indeed, we do. Really fast, antibody tests. What are your thoughts on them and them being pooled in data on state health department websites, et cetera?
Yeah. Antibodies are complicated, but I'll loop it this way. I would again caution the general public to try and use antibody testing for anything actionable other than a curiosity. I think the only thing an antibody test really tells you is that if it's positive, you likely had COVID-19. But what I worry about is people getting that and thinking that, oh, I've got, again, this sort of like passport to do whatever. I'm good, I'm immune. We don't know that yet. There's a wonderful article in the New York Times today talking about immunity that's based on a preprint publication that comes from colleagues at UC San Diego and in Mount Sinai that suggests that immunity might last much longer than we thought. It might be even longer than 3 months, but that's not something that people can easily measure. And thus, I think that's why we need to, again, continue to be cautious.
Wonderful. Well, thank you. As we wrap up, I want to reiterate a couple of points that you made, which is we all have a role in this. We don't have vaccines available for us yet. Please remember to wear your masks, socially distance, wash your hands, stay home when it's appropriate and available. Please have a safe holiday. Dr. Varkey, thank you so much. Perhaps we can have a Zoom Thanksgiving together.
Sounds good. Dr. Guest, stay safe.
Okay, bye-bye.
Bye-bye.